introduction on what's new in macular surgery. So I request now that everyone to stick to their time so they have time to discuss. And I welcome Professor Karsten to start his lecture as he's going at 12. Yeah, welcome.
Thank you very much, and thank you very much for your kind invitation. I'm sorry, but I have to catch a flight, so the taxi is probably waiting outside, but I want to share with you our experience on refractory macular holes. It's not going forward. It's not moving. Can somebody assist? It's not going forward. Okay. No, I want to get rid of this. Oh, okay. So let me start again. So I want to share with you our experience in refractory macular holes and how you can treat them. We all know that anomalous vitreous and vitreous macular traction can induce macular holes, and we were pretty amazed how nicely you can close macular holes by peeling the ILM, and with the assistance of vital dyes you can achieve a very high closure rate in macular holes. This mic. No, it's on. So I hope you can hear me. So over the time, but also at the same time, we learned from Christos Hariktoklou from Munich that without vital dyes, we had much better functional results compared to ICG. And therefore, we started in Europe a big collaboration to determine the toxicity of vital dyes. And today, we are in the fortunate situation that we have approved dyes. We know that short incubation, low concentration, don't induce harm. We have better vitrectomy systems, improved forceps, and better light pipes. So actually, macular hole surgery has become our phaco surgery for vitreoretinal surgeons. We have a standardized approach, a high success rate, and a low complication rate. However, there's still a small proportion where macular holes might persist. I always ask my patients, is it the etiology? So is this a really large old hole or a traumatic hole where you might expect a lower closure rate? What was the preference of the surgeon? Does he use ILM patch, for example? And especially in the Alps, this plays a role. Could he maintain in a prone position? Did he have sufficient air bubble in the eye? With this assumption, I start my resurgery. I always go in and start with the restaining, because you will be amazed how frequently you find remnants of ICG on the epiretinal surface that prevented the closure. There are different techniques you all know about, that with either the inverted flap you can seal the macular hole, which is very elegant, and if this is not feasible, I'll also try the free flap transplantation. If this is not possible, there are other options like to use the capsule. I've done it in a couple of times. Yes, you can seal the hole. Anatomically, it's closed. However, in my eyes, the capsule doesn't belong into the retina, and therefore you don't have good functional results. The same is with amnion membrane. I mean, I know Stanislaus, and he does really excellent surgical work. However, his functional results are not convincing. For me, the same is retinal autograft. I know Tamer very well from my fellowship, and however, I think there's still a high failure rate, and we looked for other options. So we know that with peeling and chromovitrectomy, we have a high success rate, but why are we continuing an epiretinal approach with putting something on the retina? So our hypothesis is that firm adhesions of the retina to the RPE prevent the closure. Thus, subretinal fluid application will stretch the elastic retina and close these macular holes. This idea is not new. It was firstly described by Thomas Wolfensberger 20 years ago at the Jules Gonner Club, and it took another 17 years when Mandelkorn called it macular hydrodissection. At the same time, I did my first case. This was an 83-year-old gentleman who had numerous other surgeries, and he had a giant macular hole of 1400 microns, hand motion, and his major concern was this large central negative scotoma in the center of his vision. This reminded me of my fellowship with Cindy Toth in limited translocation, where we also injected fluid into the subretinal space to detach the retina, drag it downwards, and I measured a shift of 1600 microns. So this is also feasible for macular holes. I did this in this first case, and well, when I saw these results, I asked myself, am I just a lucky guy, or is it really repeatable for others? We started a video. You can put on the tone, some of you might have seen it, where we showed the approach. You inject subretinal fluid into the subretinal space. I start with a small Decaline bleb. I advise this early on because it's easier, because you want to avoid that the fluid goes through the retinotomy, through the macular hole, and then it's not expanding. Once you have detached the retina, you can expand it, and very important is this last step, that you really detach the edges of the macular hole, and the elastic retina will be used to close the macular hole again. Early on, a few colleagues have tried it, so we started the Apostle study. These were 12 colleagues from Germany, Austria, and Switzerland. Most used 3 subretinal blebs with BSS. There were no serious adverse events. Most use the gas tamponade, and here you see the parameters of the macular holes. Duration 17 months, aperture of 1200 microns, and a closure rate of over 80%. So with this in mind, other colleagues started with this surgery as well. Here is a contest from also my co-fellow Makoto, and up to now we have more than 44 surgeons who submitted me their cases, so we have more than 150 cases. The data are pretty much the same, so we have now 1100 microns average outer diameter. Most use a gas tamponade. However, we also see a number of attempts in secondary macular holes. The preoperative data are also the same, 17 months duration. After 6 weeks, comparable to the Apostle study, more than 80% got closed with a close to 4-line gain for all patients, but now we can subdivide it. You can, for example, see here in idiopathic macular holes, as expected, you have a much higher closure rate of even close to 90%. And you have to keep in mind that 7 out of these eyes had duration of more than 20 months or were really large. And I'm currently working on this because I want to know where's the limitation, for sure, also for this technique. And I was also amazed that in secondary macular holes, we had still a closure rate of 60%, and also here you see that this was applied in high myopic after retinal detachment, trauma, iatrogenic, or other vascular etiologies. So in summary, 4 out of 5 macular holes will close this with technique. We are working on the long-term visual acuity with the closure of the macular holes. We have a constant gaining of the photoreceptors and improved visual acuity, better in idiopathic than in secondary macular holes. With this technique now available, you can also combine it, as we did it here with colleagues in the last year, where we applied subretinal fluid in addition to an ILM flap, which can also increase your function results. Very important, and we presented this at the Academy, is the close study now, that we really want to make a new definition of small, medium, large, and extra large macular holes, so that the techniques become available. But you can see that also macular hydrodissection has a high success rate in the closure rate, and especially good functional results. And we are working on this to see which technique is best to close persisting macular holes. Thank you very much.
Yeah, thank you so much, Karsten. It was a wonderful presentation. I would like the panel, if they have any comments or to argue on the topic.
Congratulations again on this achievement. I would like to ask you that how it's better, instead of results, to show us the technique, how to do it bit by bit, because here are very experienced surgeons and they would like to pick up. And the second thing is, where do you find the 40 gauge needle that you do? Because I had some difficulties in finding the needles, and they are very, very expensive when you got them.
Well, I can send you, I think in Switzerland and Europe we have them available. I don't know the name of the vendor, so that's, I can send it to you. But for me in private practice, for example, this approach is much easier compared to harvest an amnion membrane or other techniques. And so for me, you know, I think 41 gauge needle we all have, or predominantly have in our OR. We are familiar with this technique to apply it to the subretinal space in TPA when you have subretinal hemorrhages. So I think it's an easy approach. This surgery takes you, I don't know, 15 minutes, because you usually do this in an already vitrectomized eye. You just stain the retina. If there's nothing left, you can already go towards the subretinal fluid application. You do a fluid air exchange, what I do nowadays. You don't have to use silicone oil, what some people did early on, because these holes, they even behave after a long time like normal macular holes, so you have a very fast closure rate.
I just have a couple of questions. What is the incidence of edge extension, the macular hole extension, when you inject the subretinal fluid? And
there is no expansion. I think, you know, what I learned is the biggest, or people who said I was not successful in closing it with this technique, they were not able to detach the rim of the macular hole, because, and this shows the pathology. So if the adhesion between the RPE and the photoreceptors is too firm, then it will not close by any technique. And I think the secret is that not only you put your bubbles perimacular, but you also in the foveolar, you just at the edge, you really detach it, because then you can liberate the stretch retina, this tissue, to close the macular hole. And you really have the photoreceptors where you want them. But I haven't seen an enlargement of the macular hole.
the second question is about the macular massage described by Dr. Manish Nagpal for a chronic macular holes. He has published it also.
I did also a massage of the retina, and I learned this also from others. Some people, they say, I want to close the macular hole already on the table. I think that you don't have to do it. Maybe if you really do it in a very large one, but if you have macular holes of 600, 800 microns, and if they are not too old, because this is what I showed you, my concern is that in more, in older macular holes where you have a stiffer retina, this technique is not going to work, because you don't liberate enough elastic tissue that you can close it. So this is my concern.
Yeah, Dr. Nura, do you have any comments?
Thank you so much, Doctor, for your nice presentation and nice cases. I really enjoyed the publication you published. In the first case, you presented the macular hole that closed, and you managed to take an OCT post-op. What kind of tamponade did you use? Was it air or gas? In the first case?
This was, I did my first case still with silicone, because I was so concerned about it. Therefore, I did it 5 days afterwards. So this was under silicone. But also, coming back to your question, I also looked, because some people say that you have RPE changes sometimes afterwards underneath. And this reminds me again of macular translocation, where, what kind of fluid should you inject? So it's a BSS plus without the addition, so that, because there you have a nice detachment of the photoreceptors from the RPE. And also, I don't have them here, but we did autofluorescence imaging, and I advise, this is what I learned from Cindy Toes, you really should go at the arcades, because there you have more nerve fibers, and you have a stiff retina, and you just have a pinpoint lesion underneath the vessels where you really inject, but you don't have broader RPE changes. So I haven't seen this in the past.
And some people, they recommend like bending the tip of the 40 gauge needle. Do you recommend this technique to avoid hurting the RBE, or it's okay to go straight while
I didn't get this.
So some people, while detaching the retina, they recommend bending the tip of 41 gauge needle. Or you prefer to go straight? I think.
Yes. Well, I use a translocation. So I use in macular translocation. Cindy told always when she was approaching, she said to the nurse, inject, inject, inject. So her idea was that the fluid, the jet, dissects the nerve fibers, and then it goes subretinally.
Yes.
I know other guys who come from cell transplantation, they really poke the needle under the retina and then they start injecting. And I think this is a little bit more traumatic. So
True.
I try to, and you really have to exercise this if you do it manually with a nurse, because you have quite a high resistance to induce the jet through the 41 gauge needle.
Last question. What is your post-op regimen? Do you ask those patients to lay down flat for 30 minutes, then they
Yes.
will position?
So they should have, it's the same like in normal macular hole surgery, they should maintain in a prone position for the first days, and when they can see that the macular hole is closed, they can liberate whatever they want.
Thank you.
But for me, I also want to have them in this position, especially these are special cases.
Yeah, thank you, Professor Karsten. I think the key point here is that there are different kinds of procedures, and all procedures work, but the main thing what he has described is another mode of treatment when the macular hole is large. You don't have to do a retinal transplant, take an auto transplant, or do a free flap. But there is a second important point what is mentioned. If your rim of the hole is firmly adherent to the RPE, then it's not going to work. So I think you need to decide your case before you blindly go into the procedure. So I welcome next Professor Dr. Ayman for your talk.
Thank you very much, Dr. Nazimol. Good morning, everybody. Let me tell you this. I'm going to talk about the most straightforward way to do the macular hole. And luckily, you can manage more than 90% of your macular holes according to what I'm going to say. Those complicated cases are rare, you know. Last year I've done one case. I've been doing macular hole surgery since 1995. Probably I've done few cases of referred holes which were not closed. So, primary macular holes are more common in females than males, as you know, usually occur after the age of 55. There is a high rate of macular hole formation in the fellow eye. It's 10 to 15% in 5-year period following the first macular hole. Vitreous anteroposterior traction is an important factor affecting macular hole formation, while vitreous tangential traction leads to further hole expansion. Patients with vitreous traction and no macular hole, which is stage 1A or B, should be observed without surgical treatment because they often remain stable or even improve. I'm going to show you this case. This is a patient, the right and the left eye. The right eye has 1B and this is 1A hole. You can see that there's more edema. I tended to wait. 5 months later, the right eye, the retina came back to normal, although you can see that there is an operculum in the right eye, but the macula was closed, the hole was closed. In fact, the left eye, with the vertical traction, VMT, it went to stage 2 macular hole. Now, the patient wanted to wait, thinking that the left eye will do as the right eye. In fact, it didn't. It went from stage 2 to stage 4 hole. So at this stage, we had to do surgery. This is the patient, and this is the same patient 15 days after doing the surgery. You can see that there is still a gas fill in the eye and the hole is closed. Now, most patients with stage 2 to 4 macular hole will have poor prognosis without treatment. And the visual prognosis is good following successful macular hole closure or surgery. Studies report 90% closure rate or even more. In our department, it's even more. After vitrectomy in primary macular hole of 400 to 500, even up to 700 microns. Early detection and treatment of macular hole is associated with both higher closure rate and better post-operative visual acuity. Now, my approach is 23 triamcinolone-assisted vitrectomy. I do phaco in most of my patients because they have a little bit of cataract. If the lens is clear, I would tend to keep it, but I will tell the patient that he has a high percentage of developing cataract afterwards. ILM peeling with the use of dye, and I now use the C2F6 tamponade gas for all my cases with 5 days face down position, strict face down position. This is straightforward triamcinolone-assisted vitrectomy. We use a triamcinolone, as you know, just to make sure that we are detaching the posterior vitreous. This is, in fact, a 45-year-old lady. You see that the vitreous looks abnormal, but we managed to detach the posterior hyaloid. And after detaching the posterior hyaloid, you go to the periphery as far as you can and remove all the vitreous. And then you put dye, and you do the peeling, arcade to arcade peeling, just simple. I seldom needed to do any ILM folds over the macula. I think it's in the primary holes, it's enough to do arcade to arcade ILM peeling. And then you do an air fluid exchange. And this is trick, you know. After you finish an air fluid exchange, you have to check the periphery of the retina carefully, because sometimes you might find holes. Then you go back because there will be an accumulation of the fluid. Remove the accumulated fluid afterwards, and then you do the gas fill. Now I'm going to show you the post-op cases with different closure pattern, depending on the type of the gas fill and depending on the, let me say, the quality of the outer retinal layers, because this is very important, the prediction of the closure of the macular hole and the prediction of the prognosis after the treatment. This is one of my best cases. This is a fresh hole, straightforward surgery, patient after 2 months, he's 6'6". This is another hole, fresh hole, also excellent result with excellent vision. This is the same. Look at this pattern of hole closure. It's like a plug, you see, as if you have put a plug inside the hole. Also, the vision was improved tremendously. And look at this case, also, the vision improved tremendously. Those are one of my fresh cases. Look at this. This was a case that I did with SF6 gas. I did, in fact, 2 cases. One case, the hole did not close. And this was the second case. And look at the lucency of the hole, closure of the hole. I thought that this hole is going to open again. Luckily, it didn't. At this stage, I stopped putting SF6. I only use the C2F6. Now, look at this hole. If you look at the outer retinal layers, this is a chronic, long-standing hole. It's merely atrophic. And look at the closure pattern. The hole is closed, but the vision did not improve that much because of the atrophy of the retinal layers. Look again on this hole. This was not a big hole, in fact. This was around 350 or 400 micron hole. But the problem is the chronicity of the case, and you look at the outer retinal layers, it's merely they are not there. And look at the closure of the macular hole, that it's not good, and there's an atrophy of the outer retinal layer, and the vision did not improve that much. This is also the same case, and you can see that there is an atrophy of the outer retinal layer. So if definitely before doing your surgery, look carefully at your OCT. Take a very careful history of the patient. How long is the problem? Is there any viable outer retinal tissue? What sort of gas you are going to do? And the compliance of the patient. These are very important factors to predict the outcome of your surgery. Thank you very much.
Thank you, Dr. Ayman. So I have a few questions for the panelists. So how many of you would use 24/7 prone positioning after a primary macular hole repair?
27.
24/7 should be prone position?
For 1 week?
Yeah, how many of you?
No, if I do to a Greek patient, put him in 1 week for face down for 1 week, they kill me. It's impossible for them to follow the orders. It's the character. You have to remember, medicine is not something that you said to everybody and everybody is doing the same. We have different people, and the people in Greece, the first thing they say is, how long would I stay like that? Because they open up the internet and they see what's going on. And if we give them, it's 3 days, because we found out that in the first 24 hours, 80% of the holes are closing. If they don't close in the first 24 hours, then you had make a mistake in the injection. And the most important thing for me for the macular holes is to have a complete fill. If you have an underfilled eye, then it's not working because fluid gets to the hole and keeps it open. So for the first 2 or 3 days, he has to be face down. And then he has to be 45 degrees looking down so he can walk, he can eat, he can go out. And that's what we do. But also the injection system that we're using is different. We don't inject through the infusion. We use 5 cc with a 30 gauge needle embedded in the eye. When we closed all the holes first we close the hole of the 25 or 27 gauge, and then on a firm eye that we are certain that is not sending gas anywhere else, with 2 needles, we put 2 30 gauge needles. One needle is filled with 5 cc, 50% SF6, and we inject it, and the other needle is used as a valve to remove that. And this usually, if you understand the physics, it's going to complete the eye. Usually when you inject through already 25 gauge holes that have been troubled by moving on the sclera your instruments, you have a losing fluid. And then the second issue that's very important is how they put the face down if they squeeze the eye. And you see the other day they have an ifema, they have less gas. So these things are not discussed very openly. They say, I put this gas, I put this thing, I tell him to stay a week down. No, every person has a different opportunity, and we try to face the little details that can make the difference.
Let me just iterate. The hole should be closed within 36 to 72 hours. If it didn't close within this time, it's not going to close. So I think face down position for 5 days is enough. Now, the type of gas is important because it's not because of the longevity of the gas, because the SF6 stays for 4 weeks. It is because of the surface tension of the gas itself. The surface tension of the C2F6 is much higher. I think it's 5 times more than the SF6. This is why it works better. The case that did not close with the SF6, I re-injected C2F6 gas and it closes.
Usually I ask the patient to do face down, and then next day to the clinic they will come seated. So it's very rare, and those patients usually they will never listen to you. So that's why I put at the first 24 hours I try to make them face down as much as I can until they come to the clinic. Then I ask them at least to look a little bit like 45 degrees down. And usually I put SF6 gas for, and my success rate is more than 90%. So I think it's about the first 24 hours if they listen to you, and it's very rare. In my culture, it's very rare you will have those patients to face to position for 1 week. So we ask them and they will never do it.
Yeah,
Well-
thank you, Dr. Ayman.
Definitely SF6 works, but take it from me. The C2F6 is a better gas for closing the hole. If you have it, you will sleep better at night.
Yeah, so the key point is that the first 24 hours for me, if I see the retina and the hole is closed, so usually I prone for 5 to 6 hours a day for 3 days.
So why you are not using C3F8 if the in the surface station?
Well, the C3F8 is also a very good gas, but the C3F8 stays longer, stays up even more than 8 weeks, you know. The C2F6 stays around 6 weeks. And most of my patients, they come from abroad and they want to travel, you know. So I don't like to make them stay more. But it works very well also.
No, we need tamponade only for 5 days. So I welcome Dr. Subhadra to speak on macular surgery in infants. We rarely see in infants macular surgery.
Okay, I'll illustrate some points in this video, and then I have a couple of slides. So, can we have the sound also? Will it come? Otherwise, I'll speak. The cable is there. Maybe you have to switch on something. Okay. The half done. This video is now showing a 23 gauge sutured lens perimetrectomy. For infantile brain removal using a 23 gauge forceps. Be very careful while lifting the edge by releasing the nasal side of the membrane first. The temporal side will usually be very stiff and taut and have a retinal fold behind due to the elastic stretching of infantile retinas. The traction of temporal edge should be the least to prevent because using retinal membrane removal. This video is now showing a 23 gauge sutured lens perimetrectomy.
Can you anyway? For infantile epiretinal membrane removal using a 23 gauge forceps, be very careful while lifting the edge by releasing the nasal side of the membrane first. The temporal side will usually be very stiff and taut and have a retinal fold behind due to the elastic stretching of infantile retinas. The traction of temporal edge should be the least to prevent retinal breaks. Once the membrane edge reaches the fovea, be gentle and move in a curvilinear fashion to avoid foveal injury. Do not pull. Successful removal has. So what I wanted to highlight is that there will be a fold from the disc to the fovea, and it will be very tightly adherent at the fovea. So both the things we need to be careful about when we are looking at these macular holes. So what is the difference in this macular pathology from the adults? The macular configuration will depend on the persistent fetal vasculature component. So that strip that I was removing, that is actually a part of the persistent fetal vasculature component. The infantile retina can stretch as it is elastic, just like the infantile cornea can stretch, that you get a megalocornea if the pressure goes up. And this doesn't happen when the child is a toddler. So this is very specific for infantile retina. So whenever you see these folds, these drags, the pathology has started at birth and it has progressed in the first few weeks of birth, and that is why the retina can stretch. Later on, the retina cannot stretch. So you don't see these folds, let's say in diabetic retinopathy. There you will get a tabletop detachment. You will not get these folds. And this is often progressive because once this drag is there and the vitreous is adherent, as the eye will grow, it will lead to progressive macular problem. So just to illustrate, the shape of your macular pathology will depend on where that persistent fetal vasculature stalk is there. If it is not there, then you will only get a circumferential detachment and your macula will not detach, and you will get a flat macula and not a dragged macula. But if there is a central stalk, then this macula will drag, and you can see it will form that fold. And the nasal side will also pull onto the temporal side. That is what that causes that fold, and the stalk is in the depth of that. And this happens not only in ROP, it can happen in FEVR. So these are two cousins. You can see why the retina is different. That stalk is different, that volcano-like lesion or elevated falciform fold, it will happen because that persistent fetal vasculature, how it is adherent to the disc, what is the extent, and how it is dragging the retina. So the nasal retina has come on the temporal side because the stalk was up to the nasal side. If it was only at the temporal side, then you will get something like that. So the configuration will vary, and you need to understand that pathology. It can happen in Coats disease. So you can see here Coats disease. This is without a stalk, that is with a stalk. And sometimes that stalk can be very big. If you inject Avastin or you inject Triamcinolone or Ozurdex in a Coats eye with a large persistent fetal vasculature, they will come back with a reg-RD. So you need to be cognizant that all these infantile disorders can have a component of persistent fetal vasculature. This case I will show you on video also. So this is bilateral hematoma. You can see in the right eye, it's a very tiny hematoma. There is no persistent fetal vasculature, so there is just a thin ERM. But in the left eye, you can see that configuration. It has appeared like an hourglass pattern. That is because it is attached to the disc. It has caused a dragged disc. It is attached to the fovea. It's caused a dragged fovea. Now, if you do OCT, you cannot see these changes because that membrane is so thick and the underlying hematoma is so thick that you can't see these adhesions. But from the configuration, you can make out that there is a disc and foveal adhesion. So let us look at this case on surgery. So this is the standard 23 or 25 gauge, whatever you like, basic core vitrectomy we are doing now. Just see, we are removing the vitreous from there, and this whole membrane, I'm just removing the vitreous over it. Now I'm trying to find the edge of that membrane, and usually the edge is quite clearly visible. And I'm starting it from the non-disc side, because in the disc it is very much adherent around the disc, and I cannot see how far it is in the depth of the disc. So alternately, I am using the cutter, and now you see here at the disc and fovea, how the disc and fovea are dragged to each other. Now here, if you pull, you will create a macular hole, or you will create severe bleeding if it is adherent to the central retinal artery. So you have to go in a shearing fashion, just like you do your macular excess or your capsular excess, and then it will come out easily. See that knot of fibrotic tissue in the foveal area. So this is a through and through fibrosis. If you pull it, it will create a macular hole. So you can, but the plane is there, it is like a peg. It is not very deep. So if you judge, that is like a peg, and then you slowly remove, as I showed in the last video also. Now there will be tentacles under it. So these tentacles, sometimes you have to release with scissors. Sometimes you can release. I will show in another video where I had to remove it with scissors. Here it was coming. So you just keep on pulling and see how much of retina is moving. If retina is not moving, then it will come off easily. And then you can, of course, eat it away. And these eyes can also have peripheral retinal avascularity, which you may have to laser. Now this is another case where I did not use any forceps. You will see here I have just used the cutter with, of course, you will notice that the heart is in your soul. So this is an FEVR case where the macula is now dragged, and we need to differentiate. As you are seeing, I am not using any dyes. In most of these eyes, I am not using dyes because I can see these lesions quite well. But if you want, you can put triamcinolone. So here I am trying to cut the white areas. You should not cut any of the gray or yellow areas. Those are the retina. The white areas are the stalks. So here we have, removed this stalk here. This is all persistent fetal vasculature. And then the other stalk. So again, no traction on the periphery. And now as I am cutting it, you can see it's adherent to the fovea. And now I can either do a bimanual or a scissors, or be deft, and then you can just be careful and you can release it from the underlying fovea. So you can release it, but you can see that the vitreous is draped around that fold. So it will be draped, and then it is going into the disc. And once you remove it from there, then you do a vitrectomy on the nasal side, so that there is no traction on the nasal side of it. Always, as I showed in the first video also, it will be adherent to the nasal side if the disc is dragged. If the disc is not dragged, then it doesn't have a nasal side component. So this is the last case that I'm going to show. This was just done last week. This is a case where somebody has injected Ozurdex in a Coats disease eye which had a persistent fetal vasculature. Now see this one, here actually the fovea is closed on itself. And this is going right deep, this membrane is going right deep inside. I'm trying to remove it, but I realize that its tentacles are within the folds of the two sides of the arcade within the fovea. And so I used a scissors to trim it. And then the last bit also I removed with a forceps very gently. You can see here. I'm still using a scissors only to keep on trimming it. I'm not using a bimanual. And you can see how those tentacles were there. When you're pulling, I have created macular holes many times, and it was like, my learning curve, I learned that I should not pull it. I can tease it, and slowly by teasing, those tentacles can come out, and then you can remove these membranes. So that's just what I wanted to highlight. And this is the other case where you can see that this persistent fetal vasculature is pulled up. This is an FEVR case, and as I was trying to remove the membrane, the hemorrhage, small hemorrhage on the disc happened, and that is why we should stop. Otherwise, it will avulse your retinal artery. And that is why that small stalk we just left behind. We just trimmed it and left behind, and that arrow I have placed there to show the area next to that area is very thin. If you try to drag it, you may create a giant tear in that thin retina. So these eyes also have associated thinning of the retina around them because their vascularity has not happened because of the persistent fetal vasculature. So I want to conclude by saying that macular surgery of infantile onset retinal conditions, you can have these cases also coming to you as adults, should take into account the variable disc and foveal adhesions of the persistent fetal vasculature. On the disc, the adhesion could be of variable extent, either in the center or at the edge, or it can be adherent to the central retinal artery. And in fovea, it could be like a surface plug, or it could be like a deeper peg, or it could have stellate lesion with thin tentacles, or it can be adhesive and full thickness scar. So once you judge those, if you have an intraoperative OCT, of course, that would also help to decide the way that you want to remove those membranes. Thank you.
Yeah, thank you, Dr. Subhadra. Anyone has a comment?
I always admired your presentation in Retina Awesome.
You're very
I'm a
kind.
big fan, and I was trying to have you in real life, and I was really impressed with what happened today. One question is, in the first case, did you use 20 gauge for this difficult case of removing the membrane from the macula? Did you use 20 gauge forceps?
So this was in 2005 or 4 I have done this surgery, very old surgery that I have shown. Yeah, it depends on, now we are using 25 gauge or 23 gauge. This was, I think, many, many years back.
But 20 gauge forceps have a much better grasping ability because they have a much wider surface area. So you don't have to put strips of membranes. You can hold it better. So sometimes when you have this kind of membranes, I would prefer also myself to open up a little bit and get, just remove the trocar.
Yes,
and get
yes.
with a 20 gauge
Yes,
to
definitely.
use some 20 gauge instruments we have, bended or whatever, that they are very useful. So I'm coming back a little bit.
Yes,
I'm
yes, I
using-
totally agree. There's nothing, there's no ego in that. We can use, that one with the flat tipped end which is little curved. We can use that. Whatever we judge on the table, and we have all the instrumentation and we've used a lot of them, then we can manipulate. That's why I tell all the residents and fellows that keep on trying new things. Don't keep on doing the same thing. Because you never know where you need to use something else. If you are good with your tools, then you can, improvise. Thank you.
Thank you very much for an excellent presentation. And let me now welcome to the stage a dear friend, Dr. Athanasios Nikolopoulos from Greece, and he's going to talk about how useful is the 3D niguity in macular surgery. Please.
Now, from 20 gauge, we go to 27 gauge. And the 3D that I'm using for the late years. This is, can you play the videos when they are starting? This is the impression we have when we need to do some macular surgery with ingenuity. You can see the distance, you can see how all the eye is completely filling, and you see the vessels clearly, they're even pulsating or whatever they do. So we have an option that you never had before with the best microscope. And what are the privileges of what this system? First of all, the light pipe. It's 60.8 lumen normal light pipe. This is what you have. And the phototoxicity for the macular surgery is 14 minutes. And for the ingenuity, the phototoxicity can keep you up 2.5 hours of trying to remove the ILM. So let's say that the ingenuity is very good for people who are learning something. So they don't have to do phototoxicity while trying to learn a new technique or a new method. So for the young guys, that's good. What about the digital depth of field? Sorry to say, but getting older, you're losing depth of field. And it's my personal observation. I don't have to look for you. So it's 2.9 greater depth of field than the best microscope. If not that good for people over 50 or 60, what's good then? So for young and for old, they have some plus. And let's go to a little between old and young, middle-aged people, middle-aged surgeons. No need for accommodation because you have this 50 centimeters away. So even with a microscope, you need to accommodate and change it. And also the things that I don't say here is that it gets tall and short people to get easy doing a surgery without having to adjust the microscope and having the inverter in the microscope. We try to learn people how to use the 3D surgery in Thessaloniki, as I told you before, in this Thessaloniki Vitreoretinal Summer School we do for a week every year. And this is July 3 to 7. You can see that we have all the systems set up, and all around us are Ingenuity system where people are trained how to use this system by experts. And I'm talking experts like Riemann, Aberg, and people who actually invented the way of doing this surgery. And now, can we play the video? I will show a 27 gauge macular surgery, and look how big and how clear the eye is. We have changed the 3D presentation to 2D because we don't have yet projections that they can show 3D. In order to project a 3D, you need two projectors. So is not impressive to see the lumen? And another thing is how easy you can get into the 27 with the trocars. And now you can see the depth of field while injecting the Kenalog. You can see the bottom and you can see the top of your view. And that's the usual thing when you have a macular hole. You usually have a cortical vitreous attachment, a strong cortical vitreous attachment that sometimes we think this is producing the macular hole. And you can see it clearly while you try to suck it out and do a vitrectomy. So it's a 3D video in 2D, to transfer in 2D in order to be able to show it. And also, this is the finesse system we've got, the 27. And you see we try to scratch the retina in absolutely controlling it. And we control it so much that actually we didn't scratch it at all. If you control too much, you have to control much less than that. So we're re-scratching. That's the finesse is doing. You can re-scratch and repaint. We're not afraid to paint the second time because by just trying to lift, the most difficult thing is the beginning of the ILM removal, not the end of it. So this is what you see. And this is the 27 gauge tip, which is very, very small and minute. And here it looks very, very big and very safe. And this is what I told you before with 20 gauge and 27 gauge. It breaks the small tip of the 27 gauge. So they are making now tips that they're expandable, and they try to make it wider. But no matter what, you can see the details and you can do whatever you want. The other issue of the Ingenuity is that you can actually control the level of magnification you never had in your life. Because that's the most important thing. You have a wishful magnification you never had before with a microscope. Because with a microscope, if you magnify, you lose the resolution. With Ingenuity, if you magnify, this is what you get for resolution. So you don't lose the resolution for a high magnification. And let's see if it works underwater. This is underwater. And we tried to take some fluid. You see, there was a flick of vitreous in the macular hole. And you see the control you're having with a 27 fluid needle. You can actually drain, because this is another important issue of a whole surgery. You should drain the eye from fluid. And this is the visual, the image you have under air. We're using the ABO system for the visualization of the eye. And we're using the XL system here, not the macular system. And now we're exchanging, we're putting the valve in order to fill up. And this is it. And without Ingenuity, you just got a blackboard. And I'm expecting to have some questions because people are doubting that you can use it so often.
Yeah, very nice presentation, explanations of advantages when you grow older. that I understood. But I want to put a question to you. In next 5 to 10 years, where will these 3D visualization systems?
Can you stop using the microphone so I can hear what you're saying?
Okay. Next 5 to 10 years.
Next 5 to 10 years.
Where this 3D visualization system is going to stand, and is it going to replace our conventional way of doing research?
The next step that we're seeing, you must remember that visualization in microscope, physics for the microscope, for the optics, has an endpoint. You cannot improve anymore the optics. Already the optics we have are 20, 30 years old. So the only thing that doesn't have a rooftop is digital. Digitalization doesn't have a rooftop. And you can see, if you present something to a microscope, only one person can see what you're doing. The person who catches it to the microscope. Because if you look what he's doing from a screen next to you, your vision is 1/10 of what the surgeon sees. So only one can train. With this digital system, you can train the whole world. Everybody can see you exactly what you're doing. And you have the participation. This is another issue that people don't understand if they don't do it. You have the participation of the theater, the nurses, because when you do in a black area, a small surgery or vitrectomy, nobody likes you anymore because they just sit around doing nothing. But when they have this screen, everybody is involved in the surgery, and you hear the nurse say, no, don't pull so much. It's a football game now. Everybody is participating. So didactically, digitalization is something that everybody should have so that they show the same thing. And in the future, it seems that they are going to try now to make something that doesn't have a microscope at all. And it's going to be much cheaper. It's going to come just the 3D visual system, and they have it already done. And it's going to be around $50,000 this one. And the next step they're trying to do is the helmet that the Israelis are doing now from the airplane, so you can have a virtual image through the helmet and you can work with the helmet. So that's the future. The future is not going back to the microscope. You have to teach yourself. That's why we're doing the PDA. You have to teach the technology, people who don't have direct access to this technology, to get acquainted with it, to get together with it, and then they can use it. If you don't know how to use it, you don't like this thing, you don't have it. And it's simple, it's for everybody.
Request Dr. Hussain to present.
Good afternoon. So I should use this one. So good afternoon, ladies and gentlemen. My talk is about the optic disc pit. It's not only the optic disc pit. There is two things that I will go through this my talk. This is our novel technique that we started in 2017 late. So I have no financial disclosure for this talk. I will describe a 40-year-old male. He has the best corrective visual acuity is counting finger, and he presented to me with the optic disc pit that was open and with the secondary macular hole. It means that he has already underwent the vitrectomy for optic disc pit, and what the first surgeon did, he did the ILM peel with the optic disc pit. So obviously what should have been done? The thing has been done, it's converted into the secondary macular hole. So, I didn't have much options. There was no ILM over the macular area. Pit was open, VN was counting finger. So, two pathologies, both have that strange outcomes and not much data. So, I gone through the literature, I couldn't find much support for the secondary or refractory macular hole and optic disc pit surgery. Many people do pit surgery, but what are the outcomes are very variable. So I will show you over here. Here you can see the open optic disc pit and a refractory or secondary macular hole, whatever you name it. But it's a secondary macular hole. In this slide, you can see the large excavation of the optic disc pit And here is the macular hole. Macular hole is not big. It's ranging from 600 micron meter to 800 micron meter. But the issue is not the size here. Issue is that you don't have an ILM over there, and how you will close the optic disc pit and how you are going to close the macular hole. So two problems. So after doing a lot of brainstorming, I came to the idea that I should plug the pit. The options that have been used previously to plug the pit with the sclera, plug the pit with the amniotic membrane, it doesn't work because there's a lot of pressure coming from the behind that doesn't let to stay any amniotic membrane, any scleral tissue, and you cannot plug it closely. So what to do? We have large series, but we were not successful for long term having a good results of optic pit surgery, whatever the techniques has been described or invented. So I choose a punctum plug that the oculoplastic surgeons, if we have, they choose it for the punctum of the lower or upper lid. So it looks strange, but you will see it as it was made not for the punctum, it was made for the optic disc pit. So our plan was the plug the macular hole. I'm using the word here, the plug the macular hole, but I don't plug it. I will tell you how it's different from the RISO. Recently we published a different technique than the RISO. We don't plug it. So, and to close the pit with the punctum plug. So here I am using, this is the punctum plug. I have no financial disclosure for this Vera plug, so they are doing this. So this is disposable and this is sterile plug. So if you go through, I don't have a pointer, if you go to the shape of this plug, it looks like a peg that can close any hole or any pit. So I took this idea from here, and here I will show you the video. Can you run the video, please? So the same patient, I've shown the OCT. Can you dim this light, please? Switch off this light. So here you can see the optic disc is open, pit is open, and there's a macular hole. I am taking this punctum plug. This patient has already underwent vitrectomy, so no vitreous, no ILM. So I am holding this punctum plug with a 23 gauge end grasping forceps, and I'm going through the 23 gauge valve system inside the eye. Here you can see like a bullet, it's going with the end grasping forceps. Just focus on the pit. I'm using wide field light for it. And just slightly you should hit the bullseye. You cannot hit the disc, so I am just putting it inside the pit. By putting it first side, you shouldn't push it much, you just have to check the position. Now the position is accurate, it is sitting inside the pit, I can see. Then you can tap a little bit to go it deeper inside the pit. Because if you will leave it on the surface, it will come out. So it wouldn't stay there. As the amniotic membrane graft and your ILM grafts, they come out. So how nicely you see it is staying over the pit as it was made for this pit. So now the second problem is refractory macular hole. So here I am using the amniotic membrane. I don't plug the refractory macular hole with the amniotic membrane. I just put and lay it over the macular hole and slightly dip. The idea to plug it doesn't help any visual improvement, and it wouldn't help any time. So don't plug the macular holes with any tissue. You just need a scaffold to cover these holes. These holes will close by itself with the centripetal movement of the tissue. So let the nature play the role rather than intervening the macular holes a lot. So here you can see the pit is closed and macular hole, refractory macular hole is also closed. These are the post-op images. You can see the plug is lying in the pit and pit staff is closed. Amniotic membrane graft is lying over the macular hole, and you can see here, you can see this is type 1 closure of the secondary macular hole that you rarely get in any condition. So this is the perfect condition to do this. This is at the end here you can see the closure of secondary macular hole and closure of the optic disc pit. So this was from the earliest cases. This is my second case for optic disc pit. if I have the time, the same. Can you run the video, please? So this case has the different situation. This case has only the optic disc pit, but there is no macular hole, because this was the primary case that encountered eye. So as you know, in the optic disc pit, you have such like vitreous adhesion, and you have a Retina there, and you have to stay in it with the tramcell alone to get a complete removal of posterior highlight. So again, this is the punctum plug, but here the punctum plug is of large size because of the pit size. So it is very difficult to have a punctum plug similar size of that is pit. So you see there's a little bit difficulty getting in with the 23 gauge, but you can do it because it's very elastic. No problem basically. Same, you have to hit the bullseye, you cannot touch the surrounding tissue and just go inside. Not very different from the first case, but just to show it that different size may have a difficulty in putting it. The similar condition. So just be patient at this step and find the perfect area to push it. Just place it, feel it, it is there, then come out and just tap it little bit, not much, not less, to keep it inside. So here you can see it fits nicely. So this is our, we have a case series of now 9 cases. Our longest follow-up is after 4 years plus. So this is the only technique that I see in last 16 years where with the optic disc pit you can have a long-term perfect dry maculas. No other technique didn't work in last my 16 years. I have few more videos, but I think we don't have the time for this one. If somebody would like, he can visit my YouTube channel. He can find it over there. A lot of videos are about optic disc pit. Thank you so much for your kind attention. And these are the post-op images if you want to see. So this is one more video. So this is the publication of our novel technique. And this is the conference that we are having this year in December in Lahore, Pakistan. You all are invited. Please do join us. It's in December, 7 to 11 December. So thank you so much for having me here, and thank you so much for your patience. See you soon.
Yeah, thank you, Dr. Hussain. Let me ask the panelists, they might have some question or comments on this innovation.
There's a lot of echo.
Thank you very much, Hussain. You know, whenever I listen to your lectures, I'm always amazed with your innovative vision. The plugs that you use to close the bit, does it have any problem as a foreign body in the retina?
Size.
Any?
Commercially, this plug, sorry. Okay, so first thing is about the size. It is available in 3 sizes, small, medium and large. You just have to calculate the size of optic disc pit and then choose the diameter of that plug. Second, it's foreign body, but it doesn't harm. I have a 4-year experience of this plug. People have a lot of controversial questions about this because they don't dare to do this. I did the microperimetry, no harm to nerve fiber layer, because if you go to the optic pit anatomy, the pit is covered with the glial tissue. There is no neural tissue. And there is no nerve fiber loss and nothing. The first patient, second, third, they are all doing good. But don't think this plug will resolve the fluid in next day. Never. It never happens. Even with this side plug that I showed you, it takes more than 6 months. But believe me, it never comes back. With every other technique, fluid comes. 2 years, 3 years, 4 years, it will come back. But this, it will never come back.
Yeah, thank you. Anyway, the plugs are approved to be used in the eye, so I think we plug it the lacrimal punctum. So
If you have a case like that, to send it to Pakistan.
yes,
Because there's so many few cases each one of us have. How many cases each one of us have? I had 2.
I have only 8 cases.
So when you have a very seldom these cases, the best thing to send them to the center,
yes.
which specialize on that,
Yes.
putting a black.
Or bring him and get it done.
So the next patient I've got,
Because you don't, because the pit you get in 1 year, 2 or 3 pit cases in whole year. So some are not qualifying the criteria, so you hardly get a 1 or 2 cases. I have the only 8 cases with this technique. With other techniques, whatever I did, I don't mention these are 3, 4 cases. I mean, in whole career, I got 13 or 14 cases.
We always afraid that my plug is smaller than the ball, and the plug if it's smaller, it goes up the head.
No, I tell you, I had the issue. I couldn't calculate the proper diameter. It was a large, but I thought it medium will fit. I fit the medium one. Next day, it was dislodged, but I rechanged it. Nothing happened. It was just lying in inferior.
Well, I think we'll continue. There is a next session.
Yeah, but would you do this surgery in a patient with good vision?
So I welcome Dr. Dinesh to start his talk. I think the next session is waiting here. Hurry up.
Okay. Yeah. Thank you. At the outset, I must thank MEOM for inviting me for these presentations. Now let's come to myopic traction maculopathy, which is actually a continuum of progressive traction changes starting from myopic retinoschisis, which could be foveal or parafoveal, all the way to a foveal retinal detachment, or a retinal detachment then extending to involve the posterior pole. And finally, you could have the formation of a macular hole in addition or independently in these cases. But the important thing is these are all associated with a posterior staphyloma. Now, if you look at this diagram, there is, of course, focal pull by the vitreous because of the staphyloma, and because the hyaloid is taut, so you have a tangential traction. But more important than all that is the fact that the ILM is the most elastic part of the retina. And elasticity means the tendency to revert back to the position where it was, physics-wise. So if the ILM is there, the retina will revert back to its position of traction. It will not settle down in the staphyloma. You remove the ILM, the retina now is plastic. It will follow the retinal curve and it will follow the staphyloma. So this is the most important thing. And this ILM is thickest in the peripheral foveal area. It not only is more elastic, it's also a scaffold for cellular proliferation and for retinal pigment epithelial cells. Now, we know that 1/3 of highly myopic eyes with staphyloma will end up with traction-induced maculopathy. And I've already discussed the various forms that happen. But the important thing is that there is not only you have vitreous traction from on these highly myopic eyes, you have ERM formation, you have remnants of cortical vitreous plaques, even following a posterior vitreous detachment. Perifoveal PVD, and most importantly, the taut, highly elastic ILM, which is the most important cause. Now you see here the progression of a patient who had high myopia with a macular hole to severe retinoschisis, not operated till this stage because no effect on vision, finally developed a detachment, and following detachment surgery, vitreoretinal surgery, a stage 2 closure of the macular hole and of the retinal detachment. Barbara Parolini is the one who's done a lot of work on macular traction retinopathy, and she has classified it based on tangential and perpendicular evolution into stage 1 to 4 and A to C, depending on whether there's a macular hole or not. The important thing is, for her, she starts with the recommendation of PPV, also sometimes in a lamellar macular hole. For her, the mainstay of treatment is a macular buckle from stage 2 onwards, that is a retinoschisis with full thickness or lamellar macular hole. And she believes in a PPV mainly in patients with associated macular holes. Yes, we do have these both options, macular hole as well as vitreoretinal surgery. And vitreoretinal surgery, the critical steps are the layer of vitreoscheisis must be removed, the ILM must be peeled at least till the edge of the staphyloma or beyond it, and you put silicone oil if there's a retinal break or a macular hole present, but not otherwise. So my recommendation would be no surgery for a lamellar macular hole because it doesn't affect the vision. PPV is the mainstay of the treatment and a macular buckle only for non-responders. In my hands, I would like to do a surgery for macular traction, myopic traction maculopathy only if it's causing a detachment at the posterior pole or more, with retinoschisis, with or without a macular hole. There has to be some progressive vision loss, which I've documented, and I would not generally operate a patient with vision of 612 or better. It's only if it goes below that that I would like to operate them. This is just to show you the vitreoscheisis where there are cortical remnants. Now, if you see carefully in this video, after we... It's not working anyway. So you can see there are few crystals left, and you try to, when you remove them with a diamond dusted, I was talking yesterday, this will not come out except with a finesse loop or with this diamond dusted. It cannot be removed by using the suction with a extrusion needle. Now, this is another patient. These were remnants, but very often you can have a complete layer. Now, if you see in this patient, after you remove the excess triamcinolone, you see there are crystals, and that's the clue for you, that there is this layer extending there. You start removing and you see there's a whole sheet, and you start, now, you cannot pick this off with a forceps. It will just tear apart. You cannot get them in one go. So here you can see we separated it out. Once it's reached this stage, you can use an extrusion needle, but not before this stage. And in this case, you will see that this is all the way here and also going up to the equator almost. So you need to remove this sheet to the extent possible safely, and which is what we've done in this case. This is to show you how, after you've done the removal of that sheet, and now you're removing the ILM, when you're removing the ILM, you realize that if there's a detachment, you lose the counter traction, and sometimes it starts pulling on the retina too much. So I prefer to use PFCL at that stage once I have a good flap of the ILM. As you see over here, we managed to come all the way, and then when we went downwards, the detachment started pulling, and I didn't want to pull on this too much, so I decided to put some PFCL. And after we put the PFCL, you will note that we're just going to put PFCL now. And after you put the PFCL, the retina stabilizes, and removal of this ILM flap becomes very simple, and there's a counter traction coming from the PFCL here. So this is, you can see how easily it comes off once you've got the PFCL there. And I always move towards the macula. I never move away from the macula. I don't want to pull on the macula. Now, but PFCL is not a panacea for all our problems. This is a situation where there was a severe myopic chorioretinal atrophy along with a macular hole and detachment. So I created this, you can see I created small flaps using the 26 gauge MVR blade. You just brush it. You don't need to, you have to just brush at the surface and this flap gets created. So I don't pinch then. And then I put in PFCL and look what happens. I've lost the contrast. I can no longer see the contrast. I can't see where the flap is. So I was forced to actually remove the PFCL again because I get better contrast in a detached retina than in an attached one. So after removing this, I create enough of a flap You can see now this flap is big enough. And then I put the PFCL back again. And this time I have enough of a flap. I'm sorry. Now you can see the flap is easily seen now, and then we are able to I'm just trying to make it short.
Yeah.
Now you can see the flap is easily visible now because it's big enough. The important thing is to keep it in one piece, because if I pull off and part of it goes away, the whole flap will disappear again and I will not get the edge. So this time I'm being careful not to lose the edge of my flap, going all the way to the macula, holding it from the peripheral edge so that the whole ILM comes in a circumferential manner. And finally, it comes off. So this video is only to show you if you have a localized detachment, you don't need PFCL. You only need the PFCL if there is I'm not going to show the video. Because this had only a localized detachment, we didn't need PFCL, we were able to do the flap easily. One word of caution, in these highly staphylomatous eyes, just see what happens if you're not careful. Here, you'll see that when I was separating out the vitreous layer, this chytic layer, I went to the edge of towards the edge of the staphyloma without visualizing it. And the moment I go there, you see, lo and behold, we came to that edge, and here, we hit the edge of the wall of the staphyloma, because that has a separate contour from the rest of the retina. So if you're not careful, you could hit that contour. Sometimes you could even get a break. Here we got away. These are just few cases. This is a localized detachment. You can see over time, no oil was used, only gas, and it settled down over a few months. The fellow eye had a localized retinoschisis, not affecting the fovea, no treatment was done. This is another patient, again a localized detachment with retinoschisis, underwent surgery, settled again with gas. This patient had a detachment which was more posterior, more anterior, going beyond the staphyloma. We put silicone oil in this patient and the retina settled well. This is another patient who there was an increase. You watch from 2013 to 18, increase in retinoschisis, developed a macular hole, treated, and she's okay even 3 years later on. And this is the fifth patient. Now, basically, this is the last slide. ILM peeling helps the retina to glide and bridge the macular hole. It allows recognition of any residual ERMs during ERM removal. It decreases the traction from the ILM. That's the most important thing in highly myopic eyes with staphyloma, and allows long-term settlement of the retina. And also, at the same time, if there's some part of the vitreoschitic layer left, it helps you to recognize that and remove it. These surgeries can be challenging sometimes, but they are rewarding if you do proper patient selection, and then you can get results which are really rewarding. One of the patients here had 3/60 vision and improved to 6/12 after surgery, but it took a few months. Thank you very much, ladies and gentlemen.
Yeah, thank you, Dr. Dinesh. I know the topic is very interesting. We can have many questions, but because of paucity of time, I will request Muhammad Taufik to present his case.
No, it's not working.
You can change it for yes. You can change it for the other one. If it's not working, you can change it for the other one. change it. No, no, it's not.
The stones are not off.
It's not working.
Remove the stone.
It's closed already.
Power is on.
You have a charger?
Yeah, charging. Yeah,
It's in.
Do you think there is a role for
Charger for the laptop?
macular buckling in cases of myopic macular hole and maculoschisis?
Dr. Salam.
What do you think?
Dr. Salam.
Yeah, so
You have a laptop?
personally, I have actually got at least type 2 closure in every case that I've done. So if you say that you can get type 1 closure with a macular buckle, that can become an indication. But if you've done a good removal of the ILM, and obviously once you've done that, you also remove the vitreoscheisis, I have not faced this problem of failure. You know, everyone says you want to have, I mean, Barbara's main contention was that you'll get a more regular surface of the posterior pole. But look at the other end. At the same area, you have multiple short posterior ciliary arteries. I feel scared. And it's not easy to position a macular buckle exactly where you want it. It needs two people to do it. So it's not that it can't be done, but why not reserve it for the end rather than the beginning?
I totally agree. I just want to highlight this point. Thank you very much.
It's also not working. Keep it. سيبه كده. هيجي ان شاء الله. Yes, sir. Sorry for this delay. I will speak about the submacular hemorrhage. I skipped the preparation and what you are need to be prepared before doing this surgery. This is a quick video that's showing how to prepare the TPA and how to use the micro injection cannula connecting to the silicone oil injection kit for the constellation. And this is a small tip that you need to shifting for injection profile and decrease the power of injection to 20 maximum, 10 to 20 maximum. And before you entering the globe to inject this TPA, you need to test that the cannula is working and make it drip, not jet. And then before also going inside, make it up to 0.3.2, the dryable amount of TPA you need to go. And go outside through the trocar before you shifting down, because this needle can be bended on the trocar. Inject the desirable amount, 1 pocket, 2 pocket, 3 pocket, as you are seeing according to the hemorrhage that you are facing. This is a post-operative image. And also this technique can be helpful in such a large hemorrhagic AMD. You can go through and inject multiple pupils. At this case, I just inject the TPA. I didn't inject the saline underneath the macula because it's a huge hemorrhage with a macular detached, one bubble of TPA down and one bubble of TPA up and one bubble of TPA temporal and fluid air exchange, partial fluid exchange, and this is the post-operative image. This is the pre and post. This is a case that I need to illustrate. This is a case presenting with me as a 60 years old female, Asian female, presenting with this hemorrhage. I think with this configurations of hemorrhage, it's a rupture macroaneurysm. So I decided to go and and this is the OCT, it's going with a rupture macroaneurysm. As usual, I go and inject a small bubble down, and at this case I didn't do what I'm saying in the microjet cannula. I use in this case the 0.5 or 0.6, and I feel that I inject the saline first and then go back and inject the TPA. So I feel that the pocket that I'm doing here is a larger pocket, and didn't see the distribution of this fluid. So what I'm learning in this situation that I titrate the micro-injection kit to maximum 0.2, 0.3. That's what I needed. Injecting the air bubble and fluid air exchange, and this is the second day, third day post-operative. The bubble is going to be up, the macula is slightly will be dry, the blood is going down, and this is 2 weeks after surgery. The blood is coming again underneath the macula. So I need to ask the panel, is this a rebleeding or it is a recollecting of the blood again? So if you have an answer, keep it in your mind, so I will see you what I'm doing and tell me it's a good or not. I think it's a rebleeding because in the previous photo, I never see any blood at all. So I decided to do another intervention, but before intervention, I need to consider it's already rupture macroaneurysm or it's another pathology. You agree with me, it's definitely rupture macroaneurysm. So I go again and do another TPA after 2 weeks and injecting the TPA. And this is the pictures 2 days after surgery. This is the pictures of OCT, and this is the picture after 1 month. Everything is going well, just following up of the case. Just following up of the case for 2 months, everything is going well. So, do you agree with me that for the second intervention, as it rebleeding, or you may wait as it's a recollecting of displaced blood? So I need to have an answer for this. If you face this problem and you are going with a case of submacular hemorrhage and the hemorrhage going well, but after a short period of 2 weeks or 3 weeks, the blood is coming again. I feel after auditing this case a lot of time that what I'm doing in the first surgery, I have a larger pocket of fluid down there, and this blood is going down for this fluid. The central pool is flat, but this blood is recollecting again after the air is going up and recollecting. I'm waiting for the first surgery, after first surgery, and waiting and follow up this patient, I feel that I will reach this pictures without need for second intervention. And also what I'm learned for this case, we don't need to inject fluid. We don't need to inject a larger pocket of fluid. Just inject a TPA. Maximum 0.2, maximum 0.3 amount of TPA. You need to just this. This amount of TPA will have a post-purpose liquefaction of the blood and a space for this blood to displace. You don't need to have this larger pocket. And thank you.
Okay. Thank you, Taufik. I think it's a wonderful presentation. I just want to ask one question so the audience knows. When will you use TPA gas and when will you use subretinal TPA gas?
TPA gas?
Intravitreal TPA and gas.
Oh.
And when will you use subretinal TPA and gas?
So if you have a small amount of hemorrhage, and this hemorrhage is less than 500 micron in thickness and less than 500 micron in size, and a little bit this hemorrhage is not involving the macula, I will trying the intravitreal TBA and gas. But in that situations of this case, I feel that the intravitreal TBA and gas will not working well for such a type of cases. This is my concern.
Okay, thank you so much.
Thank you.
And thank you all. I think we should conclude. My rest of my friends are waiting. Podium is yours.